Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. The feature presentation is ACC AHA 2020 Guidelines for Anticoagulants and Antiplatelet Agents. This 2020 ACC expert consensus on anticoagulants and antiplatelet agents in patients undergoing coronary intervention in the presence of atrial fibrillation or thromboembolic disease was published in 2020, and you can get a free copy of this PDF by just googling this title. Before I get into the clinical pathways as how we determine what medications they need, what medications we need to stop, and all these other parameters, let us look at some underlying fundamental concepts that we need to understand. Once we understand the fundamental concepts of anticoagulants, antiplatelet agents, and a combination of these, which could be dangerous, then we will be in a much better position to appreciate what is required of us as primary care doctors, cardiologists, or surgeons when we are dealing with a patient with the complex multi problems. 1 in 4 persons develops atrial fibrillation in their lifetime. So that's a pretty high number. Atrial fibrillation increases the stroke risk 4 to 5-fold. Indications for anticoagulation: TAD2 DS2 VAS score, which you're all familiar with. If not, you can just Google the title. 25% of the patients with atrial fibrillation have coronary artery disease. So when these patients develop acute coronary syndrome, we are faced with a challenge of giving these patients dual antiplatelet agents in the presence of an anticoagulant which is already on board. How do we juggle these situations? As we know, aspirin and P2Y12 inhibitor, along with oral anticoagulants, carries a significant bleeding risk. How do we avert that bleeding risk? How do we minimize that bleeding risk? The absolute risk is 2.2% at 1 month and 4 to 12% at 12 months for triple therapy. It also increases the death rate by 5-fold in patients with acute coronary syndrome. This underscores the importance of preventing bleeding risks associated with the triple therapy, at the same time trying to minimize clotting risk by properly selecting the anticoagulant and antiplatelet combinations. That's what this whole presentation is about. How do we balance the risk of increased blood clots versus increased bleeding? We need to keep in mind there are certain patients with a history of pulmonary embolus or recurrent thromboembolic disease, or people who are on mechanical heart valves. They need long-term anticoagulation, either with vitamin K antagonists, like in patients with valvular heart disease, or with newer anticoagulants or antithrombin drugs. And the next question is, the person also needs antiplatelet agents for acute coronary syndrome, for coronary stent, or if they undergo coronary artery bypass surgery. When we are faced with a situation like this, there are several questions we need to ask ourselves and put it on a notepad. How long does that person need dual antiplatelet agents in the presence of an anticoagulant already on board, if the person is on anticoagulants? If already on, when was the dual antiplatelet agent started? So how long did this patient have this dual antiplatelet agents? 1 month, 3 months, 6 months? We need to know that one. Can that person do fine with single antiplatelet agent? That's the key question we have to answer. When do we stop aspirin? When do we stop P2Y2 inhibitors? We have to know all these things before we can really decide, what antiplatelet agent we need to continue and what anticoagulant we prefer in these patients. Do you start people on dual antiplatelet agents if they are already on vitamin K antagonists. How long do you keep these patients on triple therapy if absolutely needed? This is a very important topic for cardiologists because many consults we get for patients going for pre-op evaluation is related to antiplatelet agents or anticoagulants. Here, patient with atrial fibrillation on indefinite oral anticoagulant who needs PCI. Now, first of all, we have to decide, is this patient on vitamin K antagonist or DOAC? And look at here. Now they want us to go to a different chart altogether. Let's see if the chart 3 is here. And here is chart 3. If the patient needs an elective or urgent procedure, it's not an emergency. In other words, you can bring down the INR to 2.0, initiate unfractionated heparin if needed. So let me leave at that and let's get back to where we were here to begin with. Here we started, and the patient is on oral anticoagulants and needs PCI. In the peri-procedure, they say follow the PCI protocol. You can load the patients with the antiplatelet agents. If the patient is not received aspirin, the patient can receive aspirin. So that's the standard in the cath lab treatment. Then in the post-procedure period, they say restart oral anticoagulant agent, and the preferred agent is DOAC if we can switch over or continue with the vitamin K antagonist. And of course, we continue with the P2Y12 inhibitor. But if the patient was already on DOAC, then we just restart the DOAC and initiate the P2Y12 inhibitor. And when these patients are on all this triple therapy, now they need to be on proton pump inhibitors and H2 blockers. And there's another part that goes below that. Let's see what is that. How long do we keep these patients on these medications? In the first month, they're going to be on the aspirin, they're going to be on P2Y12 inhibitor, and they're going to be on the oral anticoagulant treatment as it is said here. So the oral anticoagulants are indefinite. They stay without any changes. Then 0 to 6 months, we can just continue this patient on oral anticoagulant and clopidogrel, which is the preferred agent because of lesser bleeding compared to other P2Y12 inhibitors. Then between 6 months and 12 months, they say either we can continue with the P2Y12 inhibitor or switch to aspirin. So that means the patient is going to be on aspirin and oral anticoagulant agent. I don't know, as a cardiologist, I would prefer to leave these patients on P2Y12 inhibitor. That's just my preference versus just using aspirin. And at the end of 12 months, if they are on oral anticoagulant agents, you stop them. But generally speaking, if they are not on oral anticoagulant agents, we continue them sort of indefinitely. P2Y12 inhibitor, still they will be on aspirin for long term. And it's the same thing, we can continue the P2Y12 for 30 days, and between 0 and 12 months, they say clopidogrel is a preferred drug, and then at the end of 12 months, we stop both these. Hopefully, this has helped you to get an understanding. As I said, in the first month, they are going to be on triple therapy. And between 0 to 6 months, in the first month, they're going to be on all treatment. Then we switch over to clopidogrel and oral anticoagulant agents. After 12 months, they say we can stop the antiplatelet agents. Okay, now let's look at the different scenario. If you are elective versus urgently needed PCI, I already talked about this part. We just hold the DOAC, and now we have to go to another chart to look for the duration depending upon which DOAC we are using. I hope you can get to table 5. If this is an emergency procedure, if the patient is on vitamin K antagonist, you just simply stop the vitamin K and proceed with the procedure and deal with any complications that may arise at a later time. Or if the patient is on DOAC, we stop the DOAC and we follow the PCI protocols with aspirin based on the ACC AHA guidelines. Then during the CAT procedure, of course, they received the loading dose of P2Y12 inhibitor, and after the procedure is over, or during the procedure, they can receive unfractionated heparin or use low molecular weight heparin. Bivalvuridine could be used during the procedure, and after that, we decide what we need to do. We need to restart the oral anticoagulant agents, and the preferred drug would be one which belongs to DOAC group. Keep them on aspirin 81 milligrams, and we continue them on P2Y12 inhibitors, and the preference is clopidogrel 75 milligrams. And of course, as I already mentioned, we place these patients on proton pump inhibitors and H2 blockers to prevent GI bleeding. We can consider bridging, since vitamin K takes 3 to 5 days to build up the therapeutic level. We can either start them on low molecular weight heparin if there is increased tendency for thromboembolic events. Let's take this top part and see what it says. Then we're going to take this as the second segment. Then we're going to take this as the third segment. That is, patient on antiplatelet agent has new onset atrial fibrillation. This primary prevention, they say stop antiplatelet agent. Just keep them on anticoagulants. Okay, this part is done. Now let's take this part and see. This is the stable ischemic heart disease. And this is the part I kind of enlarged it. So we already covered this. Now let's talk about stable ischemic heart disease, no acute coronary syndrome. Here is the stable ischemic heart disease. Patient has had a prior PCI. The time from the PCI is if it is less than 6 months for drug-eluting stent and less than 1 month for a bare metal stent. We start them on oral anticoagulant agent, DOAC preferred. Then we stop the aspirin and continue with the P2Y12 inhibitor. So that's a little bit easier to follow that one. And when we reach the 12-month period, we can stop the P2Y12 inhibitor. Whereas if the drug-eluting stent was between 6 and 12 months and the bare metal stent from 1 to 12 months, we can start them on a DOAC and continue on aspirin or Plavix. Which is your preferred choice? Please leave your comments below. I would like to know. I would prefer to use clopidogrel just because I feel more confident with clopidogrel and oral anticoagulant agent. If the drug-eluting stent was more than 12 months ago, then we start these patients on oral anticoagulant agents and stop antiplatelet agents. This chart is exceedingly important because this is a very sound advice, because if you were to stop dual antiplatelet agent, you need some reference as to where does it say that you can stop this. Then you can go back and say, according to the 2020 ACC AHA guidelines on anticoagulants and antiplatelets, here is the chart which shows that patients who had stents for more than 12 months, we can reasonably stop the antiplatelet agents. Let's go to the next part. History of acute coronary syndrome. History of acute coronary syndrome, it's kind of cut off here. I don't know why. Anyway, so if it's less than 12 months, acute coronary syndrome, we start them on oral anticoagulant agents, and preferred one is DOAC. We stop the aspirin and continue on clopidogrel. Whereas if it's greater than 12 months, that is, we start them on oral anticoagulants and stop antiplatelet agents. So that is as far as coronary artery disease is concerned. Now this part deals with the history of cerebrovascular disease and history of PAD. Prior event or intervention. TIA, CVA, CEA. No, then you just start them on oral anticoagulants and stop the antiplatelet agents. If the patient had a carotid stenting, recommended duration of antiplatelet agent, typically 1 to 3 months post-intervention. If it is not completed, you start oral anticoagulation, stop aspirin, and continue P2Y2 inhibitor, because P2Y2 is preferred choice for carotid stent according to this guideline. Whereas if it is more than 3 months after the placement of the carotid stent, then we can just start them on oral anticoagulants and stop the antiplatelet agents. It's impossible for anyone to memorize these things, but it's very important to know the resource where you can get the information when you have a particular patient across the desk, similar problems. For peripheral arterial disease, if they had endovascular intervention, of course they are going to be on antiplatelet agents. And if it's more than 3 months, you follow the same protocol. And if they had surgical repair, still follow the same protocol, that is just oral anticoagulants and no antiplatelet agents. I hope this has been educational to you, because these are minute points. As long as we know where to find this information when we need for a particular patient, then it is well and good. How long do we continue the treatment for patients with venous thromboembolic disease? If they have DVT or pulmonary embolus provoked by like post-surgical PE, they need to be on 3 months of anticoagulant therapy. Again, in each one of these situations, DOACs are preferred over oral anticoagulant agents. For provoked by non-surgical transient risk factors, 3 months. But if they have like unprovoked DVT or pulmonary embolus, if they have recurrent unprovoked DVT or pulmonary embolus, or if they have DVT or PE in the presence of cancer, they need to be on indefinite therapy and for 3 months if high risk of bleeding expected. Okay, here we got another chart, which is patients with venous thromboembolism considered for PCI. So let's take, for example, a patient had a DVT or post-surgical pulmonary embolus, for which the recommended treatment is for 3 months. So let's say in the second month or so, this patient comes with an acute coronary syndrome and he needs an elective procedure, or maybe he needs an urgent procedure. If that is the case, what anticoagulant is the patient on prior to PCI? So we need to know, what is this patient getting? Is this patient on vitamin K antagonists? Is this patient on DOAC? Then based on that, we're going to decide what needs to be done. So I might have expanded this into 2 sections. Let's see what happens here. Okay, I'm glad I did this one. Okay, here we can see elective PCI unable to be deferred until anticoagulant treatment is complete. That is, as I said, 3 months of anticoagulation based upon the previous chart we saw. Then if it's an urgent one, if it's vitamin K, now we have to go to the next chart. Same thing, DOACs, we have to go to still on initiation dose and on full treatment. So let's go down the chart here, looking at people who have been on vitamin K antagonists or low molecular weight heparin. We follow, during the procedure, we follow the peri-procedure management with aspirin and loading of antiplatelet agent, preferably clopidogrel. At the hospital and office follow-up, these patients who are on vitamin K, if you can switch them over to DOAC, that's preferred along with the P2Y12 inhibitor. If not, we have to continue with the vitamin K, which may have to be bridged with low molecular weight for 2-3 days before it becomes fully therapeutic, then continue with the P2Y12 inhibitor. Whereas if the person was already on DOAC, you simply just continue them on this dual therapy with the DOAC and P2Y12 inhibitor. If the patient was already on full treatment, we just continue with that treatment and start P2Y12 inhibitor. And of course, this is PPI and histamine 2 blockers to prevent GI bleeding. Okay, here's a little timetable that gives, which will be again useful. All the information in this particular guidelines is exceedingly important and useful. I'm going to expand this part and take this as a second part and see what we can learn. This patient has PCI and it's for stable ischemic heart disease, has a drug-eluting stent. The patient is supposed to be on anticoagulation, 3 months, 6 months, whatever it is. And if that is the situation, in the first month, they're going to be on P2Y12 inhibitor and anticoagulants. And after the first month, we switch them over to P2Y12 inhibitor and aspirin. Once 3 months of anticoagulant therapy is completed, then we continue with aspirin. So let me recap this again. And he's already on anticoagulation. We keep them on P2Y12 inhibitors for 6 months, preferably clopidogrel. And then at the completion of the anticoagulation, we switch them over to aspirin. Anyway, PCI for acute coronary syndrome, bare metal stent or drug-eluting stent. Of course, they are maintained on P2Y12 inhibitor for 12 months preferred, and the time-limited anticoagulation is completed, then switched over to aspirin. After 12 months, follow antiplatelet therapy recommendation guidelines by ACC and AHA if the patient is on indefinite anticoagulation therapy. So let's say this patient has chronic atrial fibrillation or the patient has a mechanical heart valve, then in that situation, we continue them on anticoagulants as it is supposed to be. One important point here I just want to emphasize is we can reduce the dose of DOAC after 6 to 12 months. So keep that in mind. The minimum amount of DOAC along with P2Y12 inhibitor would be the preferred choice between 6 and 12 months, and after 12 months we can reasonably stop antiplatelet agents and just continue on anticoagulants. Whereas if it is PCI for acute coronary syndrome, they need to be on antiplatelet agents for 12 months, then we can stop that. Then we consider reduced dose of DOAC. So there are certain points we are learning from each slide. In this slide, we learn if they are on P2Y12 inhibitor and anticoagulant for venothromboembolic condition, we can reduce the dose of the DOAC. And here is a list of the anticoagulants that are available to treat patients with venothromboembolic condition. We have apixaban, which is 10 milligrams twice daily for first 7 days, followed by 5 milligrams orally twice daily. And there are some things that we need to keep in mind to reduce dose under certain conditions. And of course, we need to keep in mind the kidney creatinine clearance, which has an effect on the dosage on most of these drugs. Debakey is 150 milligrams twice daily and along with the parenteral anticoagulants, then 50 milligrams orally twice daily. Endoxaban is 60 milligrams once daily when preceded by at least 5 to 7 days of parenteral anticoagulants such as heparin or low molecular weight heparin, then 60 milligrams orally once daily. Rivaroxaban is 15 milligrams orally twice for the first 21 days, followed by 20 milligrams daily with food. And then, of course, the vitamin K antagonist, which we know, and we have deltapirin. I've never used deltapirin. I have used enoxapirin, and you're all familiar with the dosage, 1 milligram per kg twice daily for enoxapirin. So this is a patient who is on antiplatelet agent who develops venothromboembolism. Now it's the reverse. That means this patient is already on aspirin and Plavix or other P2Y12 inhibitor. Now we have to add an oral anticoagulant agent or use intravenous anticoagulation for the first 2-3 days and then switch them over to oral anticoagulants. And how do we do that? Again, the top part is similar to the previous one we saw. If the patient was on antiplatelet agents for prevention, basically you stop the antiplatelet agent and start them on anticoagulants. Now let's get to this part because we already know this part, and this is the part I showed you. if you want to just look at it. Now we go to stable ischemic heart disease who had a prior PCI, and that depends on when did this patient have the PCI. If it's less than 1 month or less than 6 months for drug-eluting stent, then we start the anticoagulants, we stop the aspirin, and continue the P2Y12 for 12 months. If the patient had a drug-eluting stent between 6 and 12 months or bare metal stent between 1 and 12 months, we start them on anticoagulant, continue on aspirin or Plavix. Again, leave your comments below and let me know which one do you prefer, aspirin versus P2Y12 inhibitor. If there is a history of acute coronary syndrome, if it's less than 12 months, we start them on anticoagulants, stop the aspirin, and continue P2Y12 inhibitor. We missed that in the previous slide, but at least we know what it is. Now let's continue on the other half of this chart, which is here. Acute coronary syndrome, we already saw that one. Cerebrovascular disease and PAD. Of course, we have gone through the same thing. We start them on anticoagulants and stop antiplatelet agents. Most of the time, these patients are on either aspirin or Plavix. For TIA, it's usually Plavix. For carotid endarterectomy, they are usually on Plavix. For carotid stent, they are on 3 months of antiplatelet agents. And in that case, we start these patients on anticoagulants, stop aspirin, and continue P2Y12 until we complete the required duration of the antiplatelet agent. This is a chart about holding anticoagulants when patients have to go for procedure or surgery. It is impossible to memorize all these things, but we just need to keep in mind the kidney function. You look at the creatinine level, look at the GFR, and that based on that, it will help you to determine if the dosage has to be stopped earlier or later. If we are doing a transradial PCI, again, we have to look at the guidance in the product description. For a transfemoral, it is, again, you have to wait 72 hours if the creatinine clearance is less than 29 ml. So we can just go down the list like this. I'm just going to let you look at it and see what is the ideal duration for holding the DOACs before an elective PCI. It is all dependent on creatinine clearance. Similarly for rivaroxaban and rivaroxaban. This is a quick summary of the anticoagulants, antiplatelet agents, and when one is already on one agent, how do we start the other agent? Or if one is already on the other agent, how do we continue the first agent or stop it? And all these things will be vitally important in making clinical decisions on every cardiac patient who is on antiplatelet agents and who needs anticoagulants, or every patient who is on anticoagulants who needs antiplatelet agents. Thank you so much for watching this pretty tedious presentation. I hope at least I have given you some concepts and I have given you a resource where you can find the answer for a given particular patient when that patient needs this double or triple therapy. Thank you so much.